Chapter 14, Medication Administration. I'll admit to you up front, this is going to be a very visual chapter. There's a lot of good illustrations and skill drills, calculation stuff in the book, so you do want to make sure you're reviewing the book with this, not just listening to the lecture. Also, with this chapter, it talks all about calculating drug dosages, drip sets, all that good stuff. Just know we also have supplemental material we'll be giving you to figure out how to calculate drug dosages. We're going to practice it. You're going to practice it all year long. So don't get too bogged down in just, looking over the drug calculations in here. Know that we will be reviewing that a lot, and you'll use it a lot. Same with, IV skills and stuff like that. Look through the skill drills. Gives you a good starting point, but just know we will be practicing this hundreds of times over the course of the year. So let's get started with that. First off, vascular access may be needed for patients in hemodynamically unstable condition, or if you just want to give them a medication, or if you're just being kind to the hospital, we can go ahead and get an IV started. Patient survival depends on your abilities. No pressure there, but it is kind of a big deal to be good at getting IVs. It will take you hundreds of IV attempts before you are comfortable and have your technique down and your system down for starting IVs. Just know that it's a learned skill. It takes a long time to develop those habits for being able to start IVs proficiently. You have to have medical control to do anything, of course. If you're not confident with medication administration, use your protocols, drug formulary, flip guide, some sort of app to figure out what you need to do. I think I've discussed that in Chapter 13 as well. You should always have some sort of app or some resource for all your medications in case you get in there and you're like, I don't really remember the dose. Do I give 1 milligram or 2 milligrams? Always have your protocols easily accessible there so you can look back on that, because you'd rather have to look something up and in the moment than risk giving an incorrect medication or incorrect dose of it. So always have those resources available to you and be able to access them quickly. Preferably offline, meaning you've got them downloaded to your phone or something like that, or have actual physical papers. You don't want to have to rely on an internet connection when you're in the heat of the moment. You want something that's going to be a little bit more fail-safe than that. Online med control is not only just for the approval of medications. You can also call them if you're not sure, or if you've got something really weird and you're just not confident in yourself. You don't want to be doing that on a regular basis, but every once in a while is okay. If you get one of those really weird cases, or they've got some sort of really weird genetic mutation and you're just not sure, call medical control, get the doctor on your side, tell them what you got going, tell them what you want to do, and then see what they advise for you. It takes all the liability off your shoulders if they give you the go-ahead, as long as you've explained it to them properly. Ensuring safe medication administration. Use standing orders or online med control, of course. Reduces liability for you. Avoid human factors that cause errors. You always want to do that. And follow the 10 rights of medication administration. The 10 rights are covered in Chapter 13. There's a big, long, let's see, I'm trying to find the page number with all that on there. I meant to look this up a minute ago. But the 10 rights talking about how to give medicines, or making sure you are reducing errors with those medicines and anything you might administer. Right patient, right medication, right dose, right route, right time, right documentation and reporting, right assessment, right to refuse, right evaluation, and right patient education. That's going to be on page 648 and 649 in your textbook. But make sure you are reviewing that. We'll kind of talk about some of those here in just a second. Use a tool to verify your dose, drug name, route, rate of administration, indication for administration, contraindications, drug concentration, and volume to be administered. Those are a lot of those 10 rights that you're covering there. It's talking about using a tool to verify that. By the time you're done with paramedic school, that tool will be your brain. You'll have a lot of these drugs, doses, routes, what they do in the body. You'll have it all memorized. But like I said, make sure you have some sort of other resource available to you that you can look back on, because you'll always, whenever you're getting into the heat of the moment and things can be relatively critical, you want to have that backup source. Okay? And practice it. Practice with all these medications that you see. That way you're ensuring you don't make mistakes. Document. You have to document everything that you do. Be truthful with your documentation. The dose that you administered, whether it was right or wrong, you still want to make sure you are documenting the correct, or that actual dose that you administered, even if you made a mistake. Name of the medication, how you gave it, the route and the rate, what time you gave it, who administered it, if it was you, if it was your paramedic supervisor, or if you had an EMT partner maybe that gave something. And then the patient's response. That's always a big one. We want to know how this medication either helped or hurt the patient. It's not necessarily a reflection of your paramedic skills. If the patient has an adverse effect, we just need to make sure we are documenting that. If we give fentanyl to someone who has a broken hip, and their pain was, they were rating their pain at a 10, and now they're rating it at a 6, and they appear more relaxed, we just need to write it down. Document it. Ensure all your equipment's on the ambulance and is functional at the beginning of your shift. Check that your medications are not expired, not damaged, readily available in the right quantity. You have enough of each medication, each vial, to give recommended dosage for all that. Ultimately, you are responsible for documentation and security of all controlled substances. Those controlled substances have a lot more paperwork behind them, as we covered in 13. You have to have 2 sets of locks, all that good stuff. But remember, this all comes back to you and your partner. So make sure you're checking everything out at the beginning of your shift. We'll see it a lot. We keep on our ambulances, we keep all of our drugs in a big kind of like a tackle box. It has some foam inserts and stuff in there, and then we also have it in our jump bag. Drugs, those jump bags get thrown around quite a bit. They're in and out of houses, on the cot, off the cot, all that stuff. They get banged around a bit. Drugs, vials, ampules, all that stuff can get smashed and broken. So we just need to make sure we check that at the beginning of the shift, replace anything that might have broken, and clean up any messes there are, of course. So make sure you check your stuff. Medical asepsis is the practice of preventing contamination of the patient using aseptic techniques. You accomplish this through sterilization of equipment, antiseptics, and disinfectants. So it's just trying to reduce infection, try not to get your patient any sicker than they already are. Clean technique versus a sterile technique. So the sterile technique would be the destruction of all living organisms using heat, gas, or chemicals. For a sterile field to exist, you have to have sterile gloves, sterile gown, sterile drapes around the procedural area, and then you also have to clean the patient. The patient won't technically be sterile, but you're cleaning all that. It's hard to do that in the back of an ambulance. We are not very good at maintaining a sterile field, but we want to do the best we can. What we're doing more is antiseptic and disinfectants, trying to clean them best we can. We don't need the sterility, or we're not going to obtain the sterility, but we do want to make sure they are disinfected best as possible, cleaning the sites before we inject them, all that good stuff, cleaning up blood. Standard precautions, of course, treat any bodily fluid as being potentially infectious. Most of them aren't, but we still want to prevent any cross-contamination, prevent getting ourselves sick. So make sure we're wearing our gloves whenever we're starting IVs, poking anybody. Anytime you are in patient contact, you should be wearing your gloves at a minimum. I will also add, as you're going through your career, get in the habit of starting IVs and not pulling the tips off your finger of your gloves. Some people I have seen that they get in the habit of pulling the fingertips off their gloves so they can feel better to get that IV. That is a terrible habit to get in. You're asking to get yourself infected with blood or feces or who knows what. So don't get in the habit of pulling your tips off the gloves to start your IVs. Get better at feeling them, looking at them, stuff like that. Just learn how to do it with your gloves on. Why even wear gloves if you're just going to tear the fingertips off? That's a very bad habit. It's kind of a soapbox of mine. I don't like when people do that stuff. All right, disposal of contaminated equipment. After an IV catheter or needle has penetrated patient skin, it is contaminated. Kind of makes sense. As soon as you're done with that equipment, you're going to lock that catheter out. You're going to immediately dispose of that in a sharps container, putting it away safely so that there's no risk of somebody else getting stuck with it. You don't want to leave it laying on your bench seat, laying on the counter, laying on the patient, nothing like that. Just dispose of it. That way nobody gets hurt. We want to also minimize our risk for any type of needle stick. A big one with that would be using those blunt tip needles there that you're seeing in table 14-1. If you're drawing medications out of a vial or ampule, those blunt tip needles are a good idea. They can't really poke you. Needleless delivery systems are always good, whether that is just a lure lock system or whatever. I think most systems probably use some sort of needleless delivery just to try to reduce the number of needles once you get that IV established. So try not to recap needles only. Just throw them in straight into the sharps. Don't recap them, if at all possible. Have at least 2 needle disposal buckets in the back of your ambulance. Have one on each side of the patient. That way you can easily get to them, and you're less tempted to just lay it down and pick it up later if you got one just within arm's reach at all times whenever you're in the back of the ambulance. Also have one in your jump kit, and that way if you're in the house and having to start an IV, you're good to go there. All right, body fluid composition. Body is mostly water, 70% roughly. Provides an environment necessary for life. Body maintains balance between intake and output of fluids and electrolytes. If you're sick or injured, you might not be able to maintain that balance or homeostasis. Dehydration would be the inadequate systemic fluid volume, so you don't have enough water in there. Signs and symptoms: decreased LOC, postural hypertension, so if you stand up, you get dizzy, lightheaded. You're just not able to perfuse the brain well enough. Tachypnea, dry mucous membranes, decreased urine output, tachycardia, poor skin turgor, flushed or dry skin. That's causes. So poor skin turgor, you pinch the skin on the back of their hand and it doesn't immediately go back down flat, or it takes a long time to go back down flat. It can be a sign of poor skin turgor. Have them stick out their tongue if it's all dry and cracked. That can be a sign of dehydration. If they're not excreting as much urine in the absence of kidney failure, then that can be a sign of dehydration. So be checking all that, and that's when we're going to get fluids for all that stuff. Some causes for dehydration: diarrhea, vomiting, GI drainage, infection, metabolic disorders like DKA, hemorrhage, environmental emergencies, high caffeine diet. Oof, that one might get all of us. And insufficient fluid intake. All of those could be reasons that you're dehydrated. Overhydration, less likely in the healthy adult to be overhydrated versus dehydrated. Most of us are kind of in a chronic dehydration, probably because of the caffeine. So less likely to be overhydrated. But with those patients with other comorbidities, kidney failure, CHF, old age, everything doesn't work, they're a bit more likely to be overhydrated. Occurs when the body's systemic fluid volume increases. Just got too much. And if you're really young, like younger than 1 month, your kidneys aren't developed quite as well, and so there's a risk of overhydration. You'll get into more of that in the pediatric chapter. Signs and symptoms of overhydration: shortness of breath, puffy eyelids, edema. Edema is your hallmark sign. So swelling, especially in the lower extremities, they're just really swollen, and most of the time they'll tell you that. Man, I've been really swollen the past couple of days. I don't know what's going on. Polyuria, or urinating too much. Moist crackles, that's going to be in the lungs, and acute weight gain. So shortness of breath and the moist crackles go hand in hand. That's going to be fluid backing up into the lungs and actually overloading the lungs with fluid. Overhydration there. Causes: unmonitored IVs, pediatrics especially, or old people with other comorbidities. Giving them, maybe you gave them a liter of fluids and you only meant to give them 100 or 200 milliliters. That can cause issues. Kidney failure is a big one. Water intoxication in endurance sports, so drowning victims possible. Prolonged hypoventilation. So someone who's been in either respiratory distress or respiratory failure for a long time could get that. That's going to take a long time though. IV fluid composition. Each bag of IV solution is individually sterilized. So as soon as you tear open that outer package, you're breaking that sterile field, and now we just want to maintain an aseptic technique as best we can to prevent any infection. Altering the IV concentration can move water in and out of a fluid compartment. It will move water. A patient's electrolytes can become altered from any of those causes we discussed before, for dehydration or overhydration. All that stuff will shift your electrolytes. The human plasma. So this 14-2 table here shows typical electrolyte concentrations in the blood and then in these typical IV fluids that we give. So if you look at it, 0.9% sodium chloride. That's normal saline. That's kind of our go-to a lot of times. It's only got sodium and chloride in it. Doesn't have any potassium, any calcium, any magnesium. So it's not going to replenish any of that stuff. Our lactated ringers will have some potassium and some calcium. So it's going to be a little bit better for dehydration and replacing some of those electrolytes that you might need. The 3% sodium chloride is a hypertonic solution, so it's got a lot of salt in it. It's going to help draw fluid out of that interstitial space and back into the vasculature, the body's trying to dilute itself down. And then half normal saline, that 0.45, is just the opposite. It's a hypotonic solution. So crystalloid, talking about the dissolved crystals in water, that's going to be the normal saline and the lactated ringers, because they have similar sodium content to what is in the body. Say 154 and 130. So those are your crystalloid solutions. They can cross the membranes and alter fluid levels. 3-to-1 replacement rule. So we talked about the 3-to-1 a little bit there. And what that's really just telling you is if you lost 1 milliliter of blood, you're going to have to replace that with 3 milliliters of that crystalloid solution just for the fluid, because within 1 hour, 2/3 of whatever fluid it is that you just gave will actually leave that vascular space and go into the interstitial area. And so just know that it's requires a lot more fluid that we have to replace based on how much blood they've lost. But also keep in mind, we're not giving them any oxygen carrying capability. This isn't whole blood or anything. It's just a crystalloid solution, just replacing water, some sodium, some chloride. And then if you're giving LR, it's got the potassium in there and magnesium. So we're giving this fluid boluses just to maintain perfusion, not to raise blood pressure, especially in the hemorrhagic shock area. We don't want we don't want to raise their blood pressure back up to 120/80. We want to give enough so we have a MAP of 65 so we're able to perfuse all the vital organs. We're not wanting to, raise their blood pressure a whole lot. We'll talk more about that in trauma as well. Colloid solution contains molecules that are too large to pass out of the capillary membranes. So this is going to be something like albumin, dextran, plasminate, and hetastarch. We don't see those near as often in the pre-hospital setting, but you might see them on transfers. Some services might carry those. But most of those molecules are going to remain in the intravascular area. They have a high osmolarity, and it can actually draw other fluid and stuff into that intravascular space to help balance out the osmosis there. IV solutions are categorized by their tonicity: isotonic, hypertonic, or hypotonic. And that's really talking about the sodium content there. An isotonic fluid there in that middle picture has the same concentration of sodium as the cell itself, that red blood cell there. So there's no water shift, there's no change in the cell shape, nothing like that. A hypertonic, which would be the left, has a greater concentration of sodium than the cell. So that would be like that 3% sodium chloride. Has a lot of sodium in there. So water's actually going to leave that red blood cell to try to, equalize the concentration of water. And so it's drawing out that water, and it can collapse that red blood cell or those cells. Hypotonic is just the opposite. So it's that 0.45 sodium chloride, half normal saline. Has a lower concentration of sodium than the cell, and so water is going to move into the cell. Could swell, could burst, depends on how much you give. So you can really change a lot of characteristics of the cell just based on how much sodium is in that fluid. That's why our go-to is normal saline. It's an isotonic crystalloid, has the same amount of sodium, so it doesn't change the cells. You start changing cell shape and stuff, that's really a physician level type thing, so we'll just keep it simple here. We keep it with isotonics. One slight deviation would be a D5W. So whenever you're giving D5W, it is dextrose, 5% dextrose in water. It doesn't have the sodium in it, doesn't have the chloride, but we're giving small doses of that, and we're mixing medication into it. And so because that is a hypotonic solution, because it's just water, doesn't have any sodium in it, it's D5W, hypotonic, it will actually help whatever medication we mix in there move intracellular, because it's a hypotonic solution there. So that's why we mix different things in there, help get into the cells better, and have a better response on the patient. That's all we give D5W for. We don't give it for hypoglycemia. We just give it whenever we mix medication so it comes into the cell. All right, hypotonic solutions hydrate the cells while depleting the vascular compartment, like we mentioned, can cause sudden fluid shift from intravascular space to the cells. That's going to happen if you're giving it rapidly. We want to just, like we mentioned with D5W, just give it very slowly. If for whatever reason you had to give half normal saline, it's probably going to be a transfer. You're going to be basing that off of lab work that you might see and what the physician thinks the patient needs. Okay. Hypertonic pulls fluid from intracellular and intestinal compartments to the intravascular compartment. So because hypertonic, lots of sodium, 3% sodium chloride a lot of times, it's going to be very salty in that intravascular space. And so all that fluid is going to rush into that intravascular space to try to dilute itself out. So it can help stabilize the blood pressure, increase urine output, and reduce edema. That's going to be like peripheral edema. But if you pull all that fluid into the intravascular space, guess what? Now you're going to be fluid overloading. You could back up into the lungs. Just be mindful of that. Again, most of the time that's going to be based off what the physician sees, with their lab work, and what the patient needs, based on, like I said, lab work and stuff like that. Not something we're going to initiate in the pre-hospital setting. Oxygen carrying solution. So fluids, like we mentioned, saline, lactated ringers, D5W, any of those don't have any oxygen carrying capabilities. Whole blood or packed red blood cells is going to be the only thing that we can give that actually might change, has the capability of oxygen carrying. Okay. It is obviously the best replacement for lost blood. If someone's bleeding out a liter, you can give them a liter. There you go. Synthetic blood substitutes, I still have not seen any of that approved that I know of, but I'm sure they're of course still working on all that stuff. The problem with carrying whole blood or any type of blood product in an ambulance is One, cost. It has a short shelf life. You're looking at like 60 to 90 days, depends on what it is exactly. And you have to keep it refrigerated. Well, then if you got to refrigerate it, before you can give it to a patient, you've got to warm it up to body temperature. So not only do you need a refrigerator, then you need a fluid warmer. So it's just a big hassle and the cost issue. So a lot of EMS services don't mess with whole blood or any type of blood stuff. All right, let's get into the techniques for giving all of these drugs that we've talked about. IV therapy involves cannulation of a vein with a catheter. Peripheral vein cannulation involves cannulating veins of the periphery. Well, there you go. That's what we're doing most of the time. Starting an IV, we're starting it peripherally. We're not starting it on a big vessel that's centrally located. External jugular would be kind of the exception to that. That's kind of that's a big vessel. It's central line kind of considering, sort of. So that's what we're doing with an IV. Starting that peripherally in a vein and not an artery. And we want to make sure we keep that IV equipment sterile. Try not to touch the ground or touch the cabinets, counters, any of that with your needles, stuff like that. Keep it clean. Gather your equipment, elastic tourniquet, cleaning wipes, gauze, tape or adhesive bandages, your appropriate size IV catheter, and the IV administration set. 10 drop set, 60 drop set, whatever it means, if you have to have that. And then your bag. Most time in EMS, you got normal saline, lactated ringers. Those are going to be your first two for fluid replacement. They must be used once they're opened. Must be used within 24 hours once they're opened. And they can come in, or they do come in different volumes. You have 250 milliliters, 500 milliliters, or a liter. They're single patient use. You don't ever use it on 2 or 3 patients at once, or you don't use a little portion of it on one patient, then another on a different one. Choosing an administration set, they go anywhere from 10 drops per milliliter all the way up to 60 drops per milliliter. 10 drop per milliliter would be considered a macro drop, and then 60 drops per milliliter would be considered a micro drop, little tiny drops. You have to get more of those little tiny drops to equal 1 milliliter versus the macro. And I think 10, 15, 20, and 30, 60 are your typical sizes for how many drops per milliliter. We'll practice with all this. This picture here on the right is going to be more designed for a piggyback system or blood, because it's got the two catheters there that you can spike one into a bag of saline, another one into blood, whatever you want. Volutrol there that it mentions is another administration tubing set. It's designed for little kids. It might be called a Buretrol, depending on what brand you buy. And it has a big container in there that might hold 100 or 200 milliliters. So you can draw out 100 or 200 milliliters or very exact amount out of the bag and just give that. That way it has less risk of overhydrating or giving too much to that sensitive patient. Typically used with the little kids. Choosing an IV site. This will always be an issue. This is part of what takes so many attempts just to see. This picture here, this guy, you could start anywhere. I mean, he's got great veins everywhere. Unfortunately, those people aren't the ones we're dealing with. Unless we're in a car wreck or something, those aren't the ones that are calling EMS. It's the ones that are dehydrated or have a lot of adipose tissue, old and frail, stuff like that, that don't have those good veins. Those are the ones that we're dealing with in EMS, unfortunately. So it takes a lot of practice. Avoid areas that contain valves or bifurcation. So you might have valves. You can probably look on your own arm maybe and see a valve. It's like a little bump right in the middle of your vessel. That's a one-way valve, pretty much. And you can go through those with an IV, but if you can avoid them, that's the best way. Bifurcation, where the two vessels might split off. Let's see if you can see this. Like right in here. See that bifurcates? So those vessels are splitting off in different directions there. So we'd want to avoid that if possible. We could go right here, right above that bifurcation is a good spot. Locate veins that look straightest, firm, round, and springs when palpated. We don't want to do it. Put in an IV catheter and then the vein immediately turns or something like that. It's just going to kink it off and lead us to issues. Limit IV access to distal areas of extremities, of course. Try not to go through any open wounds that you might see or infected spots. We want to try to avoid that. We want to start distally, so if possible, we're going to start down here in the hand. Flip it over, look at the back of the hand, start our IV down there. Then work our way up. If we don't see anything there, we can look here. Got tons of great veins there, so we want to do it. The forearm is the best spot to start an IV. The hand, the back of the hand is very sensitive, has a lot of nerve endings there, so it's kind of sucks for the patient having an IV started there. The AC, or the bend of the elbow, is an easy spot for us typically because there's lots of good vessels there, but the hospitals don't like them. You're then limiting how much the patient can move, and if they have to be admitted to the hospital, that could last for several days. And if the patient's not able to move their elbow very much over several days, that's not comfortable. That kind of sucks for the patient. So, forearm is primo spot there for starting an IV. It's easy to secure it down. Don't have to worry about it moving around, anything like that. And a lot of times there's some big vessels there, especially in this guy, where you can start that larger size that you need. There's a nice little chart or a picture with all the different veins in it. You can also go down the feet. A lot of times the feet have good veins that you might be able to see there. Arm is always our first off go-to, but if you've tried a couple times in the arm, you can't get it. You got to have some sort of line. You can look in the feet, look in the upper arm, look in the chest. Sometimes the breast tissue will give that. Anytime you're starting IV, just keep in mind you're going to point the needle towards the heart. And hopefully that makes sense. You never want to point it away from the patient. You're never going to point it towards the hand. If you're starting one in the arm, you're never going to point the IV towards the hand. That would be backwards. You want to always point it towards the upper arm, towards the heart. That way it helps the fluid go in better and all that. Choosing an IV site. Bulging veins can roll from side to side. That's true. Any vein can roll, but that's why we want to secure it down. Pull the skin very taut if possible, and practice our techniques, gripping it all the way around their arm, gripping with our non-dominant hand all the way around their arm, pull that skin taut. That way the vein is less likely to roll. You can have the patient flex their hand, maybe it might help, and of course stabilize the wrist if you need to. There's a reason that it takes several hundred IV attempts to get comfortable with this. We'll be using it a lot in the lab. You're going to have lots of practice in the lab, and then your ER clinicals give you the opportunity to start 20, 30 IVs per day. I mean, it's a lot, so you'll get plenty of practice with it all. Consider the patient's opinion. If they tell you, hey, I've got a great vein right here in my elbow, my AC, this is where everybody gets me all the time, it's always good. Okay, good enough. I'm going to try there. If they tell you, hey, you can't do it on the left side, you can only get it on the right side, take all those things into the consideration of what the patient tells you. If a patient has had a mastectomy due to breast cancer, we want to avoid starting an IV and taking blood pressures on that side. It can cause some lymph node issues and inflammation with the lymph nodes, even long term. So we want to try to avoid mastectomy, side of the mastectomy, starting an IV over there. If you have to do it, you have to do it, but try to avoid that. Or if they've had a double mastectomy, it's like, well, I've got to start one someplace. So, avoid the extremity if it shows signs of trauma, injury, infection. Of course, don't start it through an open wound. And some protocols allow IV cannulation of the leg veins. Gotta get one, you gotta get one, so go for it. There is a chance if you're starting IV in the leg that it can raise the chance of a pulmonary embolism or, a little thrombus breaking off there in the leg just because they're more likely to have a little thrombus in those leg veins. But if you need an IV, you need one. All right, different kinds of IV catheters. The most common is going to be the over the needle. That's what it's got there on the left. That's what we're going to probably be using. The butterfly, some people will tell you, oh, they can only get me with the butterfly needle. It's like, okay, well, we're not going to have that today, so we're just going to start with a regular IV catheter. Butterfly, you actually are leaving in the needle in the vein after it starts, whereas over the needle catheter, once you put that needle in, there's a little, oh, what would it be made out of, like a vinyl or something, catheter that threads in, and then you're taking the needle out. So there's no metal needle in there after you've started that IV. It's just a piece of plastic. So they can still bend and everything. Whereas the butter needle or an intracatheter, that needle is staying inside the vein there. So there's a higher risk of them moving around and actually puncturing all the way through that vein. Newer needles retract. Depends on where you work, what system you're in. You might have the auto retract, you might not. Choose the largest diameter catheter for the vein. Like that picture of that guy at the start of this, few slides back, he had great veins. You could start an 18 gauge in any of those, 16, 14, even those. Most time in anything that we need, an 18 will flow blood. 18 would be really the biggest that we have to have. Anytime we suspect, high trauma and they need a bunch of fluid replacement or blood replacement, we want to try to get those large IVs. 18 would be the minimum for that, preferably a 16 or 14, getting that larger size. That way we can replenish their fluids. They can use it in surgery a little bit better. But 18 would be the smallest that we want to do on those big trauma patients. I thought there was something else. Oh, whenever you're learning how to do IVs and becoming comfortable with all the different styles of IV catheters there are, you go work in an EMS system someplace and they've got one brand of catheter. Then you go work in the hospital doing your clinicals. They've got another brand of catheter. They might both be over the needle catheters, but they're going to have a little different technique to them, a little different feel, maybe a little different thickness too, how you hold it and all that stuff. So I always recommend, whenever you go into a new system, ask your preceptor, your nurse, whoever it is, hey, let me see your IV catheters. Do you mind if I waste one of these just so I can see your style and how to get comfortable with it? Break one open, get you a little 22 gauge or something small, pop it open and just feel how it works. If it's one of those auto retract ones, you want to know that before you get in there. If it's an auto occluding, you want to know that. So once you've started that IV, if it's auto occluding, it's not going to start spurting blood out. A lot of services don't want to use auto occluding because they cost more. And so then you have to occlude the vessel yourself. That way you don't start spurting blood out. So, like I said, just get comfortable, go in there and break one open anytime you go into the hospital. Different EMS services. That way you're familiar and you're not trying to learn how to use that IV catheter when it actually matters with your first patient. Okay? Keep the bevel side up whenever you're starting an IV. Sharp point towards the patient. Maintain adequate traction. So that person there in that picture is right-handed. He's holding that IV catheter with his dominant hand. One finger on each side, his thumb and middle finger on each side of the IV catheter, and then his index finger is going to be pushing or advancing that catheter into the skin. And then he's holding traction. He's gripping around that arm to hold traction down so that his veins don't roll. Put a constricting band above the site, several inches, 3 or 4 inches. So you want that constricting band tight enough so it's going to not impede arterial flow into the arm, but it will impede venous flow back to the heart. And so in theory, what you are doing is engorging those veins, making those veins easier to see, while still not restricting arterial blood flow. There's technically no time limit that you have to leave those on or how long you can leave them on. But just keep in mind it is kind of uncomfortable for that patient to have that constricting band on there, so we don't want to leave it on there for 5 or 10 minutes. Just put it on there, finish assembling your equipment, start your IV, and then pop that constricting band off. Most common kinds latex-free. Everything in your ambulance should be latex-free. There's too many people with allergies. If visualizing or palpating the IV site is difficult, use a device that applies more pressure. You could consider that. There's a lot of lights out there that they've come up with that help you see the veins better. Prep the site, apply traction, insert at a 45-degree angle, which is incorrect. I know it says that. You should really insert that IV catheter at like a 10 to 15 degree angle. I don't know why they put 45. You should never go. That's way too aggressive of an angle. Lower it down, 10 to 15 degree angle. Push through the skin until the vein is pierced. So once you get into that vein, you'll see blood in your drip chamber. You'll be able to visualize that in your IV catheter. And then you want to push that IV in just another centimeter or so. Honestly, you're going to drop your angle down a little bit and advance that catheter in. And so what you're doing initially, whenever you got flash, you got that blood in there, the tip of the needle went through the vessel, went through the vein, so it gave you some blood. Now you got to push it in a little bit farther to get that plastic catheter in there. You push that in, and then that's when you use that index finger to advance your catheter and lock out your needle. I know it's very much visual. Look at those skill drills in Chapter 14. Watch some videos on YouTube about how to start an IV. We're going to practice it a ton in the lab. I'm sitting here using my fingers and hands, trying to do it visually. I get it. It's a visual thing. Just know this is kind of the basics of how you're going to start it. Apply pressure to the vein, as I use my other finger here to show you how to occlude. You're going to occlude that vein so that way whenever you take that needle off, it doesn't start spurting blood out. Remove the needle, dispose of that in Sharps container. Another way, if you need to, this is at the light or the ultrasonograph to try to help visualize the IV sites of those veins a little bit easier. Allows you to see those deeper veins. There's a bunch of different styles of those, so if you have the privilege of having some sort of light or something to use, just get familiar with it and practice using that. But that's only if they're really hard to see. The majority of your patients, you should be able to just get it without any type of assistance once you've practiced. Secure the line. Tape the area to secure the catheter and tubing. Cover the site with sterile gauze and secure with tape. So the site where the needle enters or that catheter enters the skin should be covered with, we call them tegaderms. That's probably a trade name, but it's like a little plastic covering that you can see through so you can visually see where it enters the skin and also prevents any infection. You want to keep that sterile. You don't want to stick it to your cabinet or something before you put it on the patient. Try to keep it sterile as best you can before you put it on the patient. And then tape your IV down. Don't have to get fancy with the tape, making loops and tearing it in half and all this other junk. Just tape it down. More tape, the better. If they're super sweaty, put some Coban or some sort of little band around it to help hold it all down. Changing an IV bag. Stop the flow by closing the roller clamp on your drop set. Prepare the new IV bag. Remove the piercing spike and insert it into the port on the new bag. And then make sure your drip chamber is filled. Open up the roller clamp. Simple enough. Anytime you are giving any IV stuff, you want to make sure you get your air out of your system. So if you're using a J-loop or your IV tubing, any type of IV tubing, make sure you're flushing that out with saline or something to get all the air out of that system. We don't want to put air into the body. So if you have to change that IV bag out, just make sure you're not introducing a bunch of air into those lines. Okay? Discontinuing the IV line, of course, shut it off, peel the tape back, have a 4x4 or some gauze or something ready, and then pull out your IV catheter there. Apply pressure so it doesn't bleed quite as much, and then tape down your gauze. Saline lock. This is what I was talking about here, this little J-loop, or saline lock. Fill it with saline as you're preparing your equipment, and that way that tubing there is not full of air, and you don't push that air into the patient. Maintain active IV site without running fluids. Makes it easier to hook up medications to that little loop there versus trying to screw it onto the hub of the IV catheter itself. Filled with approximately 2 milliliters of saline. Depends on what style it is. Some pediatric ones might be filled with less, have smaller diameter tubes that doesn't take quite as much. Also called intermittent sites. Okay. EJ vein cannulation. EJ veins run behind the jaw. It's that big blue one there behind the jaw running down through the neck. It's not your go-to peripheral IV site. That's only if you can't get anything else and you've got to have it. I personally will probably start an IO before I get to the EJ, unless it's just super obvious and bulging out, because we want to avoid the carotid artery is going to be there, and we want to avoid affecting anything else in the neck. Also know if you start or attempt to start an EJ, you cannot, if you mess that up, you can't start one on the other side because you've already damaged that vessel, and you don't want to damage the one on the other side, and that could cause big issues because you're perfusion to the head and the brain and everything like that. So you can only start it on one side. Again, try to avoid starting the EJ if possible. Higher risk for, like I said, hitting that carotid artery. Hematomas are an issue, and then also sucking in air embolism, just because it is such a big vessel there. You can't throw a tourniquet around that or really occlude it real great and apply a lot of pressure if you blow that vein there. So that guy has a real good EJ there. Make sure you're palpating that ahead of time. Make sure it's not pulsing and it's not the carotid artery or something like that. Place patient in supine, head down position. Turn head to the opposite side of the intended venipuncture, of course. Feel carefully for the pulse. Cleanse the site. Include it with your finger. It's kind of hard to pull traction on the neck there, so if that vein rolls on you, it can be kind of hard to prevent that. Line catheter in the direction of the vein, like I mentioned before, it's always going to be pointing towards the heart, so you're going to start it towards the heart. Puncture midway between the jaw and mid-clavicular line. Stabilize the vein. Proceed cannulation as if you would for any other IV, and then tape it securely. Avoid circumferential dressings, of course. You can't put it all the way around the neck. Catheters. We mentioned over-the-needle catheters, most common. That's what all those are in the picture. Smaller the number, the larger the size of the actual needle and catheter. So 14 gauge you see there is a lot larger needle and catheter than a 24 gauge. Know that they also make even larger ones, like a 6 gauge or an 8 gauge. Those are humongous. For 90% of our patients, maybe, rough estimate, a 20 gauge is adequate. For 99.5% of our patients, 18 gauge is adequate. You can flow blood through an 18 gauge without an issue generally. And that's kind of the top level thing. That's going to be the most likely to clog up an IV catheter would be blood. So 18 gauge. The reason we start it bigger in trauma is because of the higher likelihood that they are going to need blood or transfusions, go to surgery, stuff like that. Quick volume replacement. So the larger the needle, the better, of course. If you're starting a 22 or 24 gauge, just know that once you get to the hospital, they're going to have to start another one probably. If they want to draw blood out for lab work Or if they want to give very many medications, they're going to have to start something bigger than a 22 or 24. So I would recommend 18 should be your default. Once you're comfortable starting IVs, 18 should be your default. 20 should be your backup. That's kind of how I do it all the time. Butterfly catheters, it says, are ideal, but they really are not. Only for the little kids. But again, you've got that needle still in the patient all the time. So if the patient moves at all, there's a risk that's going to continue poking through the vein. So they say maybe it's a little bit easier to initiate the IV if you're using a butterfly. But nah. Just get good with your regular ones. With the kiddos, also explain your actions to the patient and the child, or the patient and the parents, I guess you could say. Hand veins remain the location of choice, of course. It's going to be harder to get because they're smaller. Forearms, ACs, if you have to. It's going to suck. You're going to need a lot of people to hold them down, probably. If you can use a pin light or some sort of light system to illuminate those veins if you need to. Scalp vein cannulation can be difficult. A lot of times they do have good scalp veins, especially in the little bitties, less than 1 year old. You can do that. Alright, older folks. Use smaller catheters, of course, okay? 18 or 20 gauge, still give me my go-to. Puncturing the vein may cause massive hematomas. Yes, it will. Especially if they're on blood thinners. You're going to cause big bruising, stuff like that. It's not fun. You want to try to occlude it, especially if you blow that IV. Try to apply pressure quickly to try to prevent bleeding into that arm. You'll see it a bunch. Some people just come out looking like they're black and blue and all bruised up because you miss an IV, and it's unfortunate, but it's just part of it. Tape may damage the skin. They may tell you that they have an allergy to tape, but a lot of times that's a long-term reaction because the tape can be a bit of an irritant on that. Okay. Be careful using macro drips, of course, just because if you had smaller IV started, like at 20 or 22, it's not going to flow as well, and you don't want to overload that patient as well. If you're using a macro drip, there's a higher chance that, if you're not paying attention to it, it could overload the patient. Locations to consider. With older folks, their veins aren't as elastic. The elasticity there is poor. They're going to be more likely to roll. They're going to be more fragile. So you want to make sure you're getting good traction. Avoid spidery veins or varicose veins. Those are not ideal sites. They actually have poor blood flow. They're just kind of more stagnant blood there. So if it looks kind of too good to be true there with the varicose veins, avoid that. Practice, practice, practice. That's all I can say. Checks to perform after the IV administration. So that once you're getting your fluid set up, this is some stuff to be mindful of course, what kind of fluid you're getting, administration set, whether that's 10 drop set, 60 drop, that micro. Height of the bag, that can affect, the amount of gravity as to how fast it's going to flow in. Your catheter type or your size can make a difference. Constricting band, make sure you got that constriction band off there. No clamping of the line. All those administration sets include a clamp or two. If you're using that saline lock, it's got a clamp on there. So if you're having issues with it flowing, make sure it's not clamped off someplace. Positioning of the line. If it's kinked itself off, anything like that, you want to reposition it. Infiltration, something to be watchful of, especially right after you start that IV. Running fluid, your first 100 milliliters of fluids or so through it, watching for that infiltration, seeing if you get any edema, bruising, swelling, anything right there around where you started that IV. If they're complaining of pain, all that can be a sign that you've went through the vein or the vein busted open and it's no good. If infiltration occurs, of course, stop the infusion. You're going to have to just pull that IV out and then start again on the other side or away from that side. occlusions, blockage of a vein or catheter, decrease in drip rate, or blood in the IV tubing. So for whatever reason, your IV isn't flowing up properly. It's occluded off. This can happen if you're starting it in the AC in that elbow, and they bend that elbow, that's going to block it off all the time. It does. Or maybe you started it near a valve, and that fluid is, or that catheter is up against a valve or something like that. That can occlude the vessel. So just be looking at that. One thing that also, remember, you started an IV on a patient. That is a foreign body that you have introduced into the patient's vasculature. So the body's natural defense is to try to block it off, try to occlude it. And so if you've got an IV in place that maybe hasn't been used for a few hours, it might be kind of clotted up. And so you might have to start or push a flush through it to try to help open it back up before you can actually start your fluids in there. So start that flush, like I said, to try to see if it blows open that occlusion or opens up that occlusion again. Kind of move your IV catheter around there in the skin. If you can't get that occlusion out of the way, then you might have to stop the IV and start a new one. Vein irritation caused by too rapid an infusion, that's possible. Redness at the site, discontinue it. Start a new IV on the other side. Thrombophlebitis, inflammation of the vein. Depends on what kind of medication you're giving it, or also maybe you didn't clean the site very well. It can cause inflammation of the vein. Typically comes up several hours later. But it's going to be that pain and tenderness along the vein and redness and edema. So if you notice that, discontinue the IV, and then you can start another one. You want to prevent that by, of course, disinfecting the skin over the site. Wear your gloves, like we mentioned. Not touching the site after you've found where you're going to do it. You palpate for a vein, you clean it up, and then you touch it again with your glove. Well, there you just contaminate your site again. So try to keep it sterile best you can. Prevent any contamination. Hematoma, oof. This lady's all, or guy's all bruised up there from previous venipunctures. Can happen. Develops while inserting a catheter. Stop and apply direct pressure, of course. Just apply pressure best you can anytime you see the bruising there. If your IV is no good, or starts to swell up, then stop. Try not to hit nerves and tendons. Sometimes, I get it, it can be a little bit hard to determine whether you're above a vein or a nerve or tendon, especially in the AC there, in the elbow. Just practice feeling the difference between them. And if you ever do hit a nerve or a tendon, immediately remove the catheter and choose a different site. Arterial puncture, it's possible. Typically your arteries are lower down, deeper in the skin, under the skin, and veins are closer to the surface, so it's not super easy, but know that it is possible. You get a bright red spurting blood, whereas venous blood is a darker red. So it's going to be a brighter red. It's going to have a higher pressure behind it. Might spurt out, and you're not able to occlude it very well. If that ever happens, just stop your IV, DC it, and then hold direct pressure. Elevate that extremity if you're able to. Pyrogenic reactions, so it really goes back to cleaning. Try to clean the site. For whatever reason, there's a foreign protein that produces that fever. Stop the IV. If there was some contaminants in the IV bag, be aware of that. Might get a backache or a headache. Whatever's changing that, causing that fever relatively quickly. Circulatory overload, of course. You're giving too much fluid, and the body's just not able to process it. Problems may occur in patients' cardiac, pulmonary, or renal dysfunction. All those comorbidities. Shut the IV down. Raise the patient's head up. They shouldn't be laying supine. Fowler position, something like that. Put them on some O2. Monitor their vital signs. If it's bad enough and you've got crackles in the bases, you've really fluid overloaded them, consider CPAP. It's going to be our go-to for respiratory issues there. Air embolus. This is why we always flush out our IV lines, our saline locks, all that. Try to prevent introducing any IV or any air into the system. Once that bag is done, be mindful when it empties so it doesn't start sucking air into there. It does take quite a bit of air, like 200 milliliters in a healthy adult, to cause lethal effects. We never want to get that far. I mean, a milliliter or two of air is one thing, not a big deal. Our body can process that, but large amounts of air, the whole drip tubing, if you're starting a macro drip and you don't put any fluid into that and you just run all that air in there, that's going to cause some pain, could cause some discomfort and some longer term effects. So make sure you're flushing all that out. If you ever get an air embolism or suspect an air embolism, it says place the patient on the left side with the head down. And the idea behind that is you're going to trap that air embolism into the right atria and ventricle. The air is going to float up onto the right and not go into the lungs, not go into that left ventricle, and not go out to the systemic circulation. So that's the idea. If you think you've got a large air embolism, putting them on their left side with their head down. Anxiety may cause vascular dilation. So they're passing out the side of their own blood. I personally kind of suffer from this. I don't like to have needles stuck into me. I don't have any problem sticking it in other people, but if you start an IV on me, I might get a little lightheaded on you. If that happens to people, when it happens to your patients, try to help. You're talking to them before you start the IV. Hey, you're going to feel a big stick here. Don't look at it. It's okay. It's going to pass. If they pass out on you, just, of course, support the airway if you need to, but they'll come around in a few seconds, generally. Get your IV and then move on. Catheter shear is kind of a big deal. Needle slices through the catheter, creating a free-flowing segment. This is really hard to demonstrate without, or to talk about without being able to demonstrate it. So you have that over the needle catheter. You maybe get flash, you push it in a little bit, you advance your catheter a little bit, and then you meet resistance for whatever reason. And then you pull that catheter back onto the tip of the needle. Well, what can happen is the tip of that catheter is actually sheared and comes apart and is then free floating in the vasculature and can travel into the lungs, can travel anywhere. So prevent catheter shear. Don't ever try to re-thread your catheter back onto the needle while you're in the vein. And that should prevent it. You can surgically remove it. They can see it on CT because they're radiographic, I believe is the term. Something like that. So they can see it on like CTs and stuff like that. In case it ever happens. Blood samples. Obtain that same time as an IV line. If you have the protocols for all that stuff, if you're working in a hospital, you want to draw blood, you want to draw that blood before you start pushing medications through that IV line, because then you're contaminating the blood right there. Fill in the order: red, blue, green, lavender. Red blood gives life. That's a good mnemonic to remember. You're going to have to draw out 15 or 20 milliliters of blood so you can fill all those different tubes up. And each one of those tubes has a different use, has different chemicals inside of there, so they can test different parts of it. This is talking about how to get that blood sample. So occlude and remove the constricting band after you get the IV catheter. Attach your syringe to the hub of the IV. Draw out all the blood. Then put in your saline lock and flush it and everything like normal. If IV therapy is not indicated but blood samples are required, you can use a vacutainer. So it's pretty much just a needle connected to this little plastic container thingy. And you start the IV, you get the blood there, and then you directly fill those tubes off that. There's a picture of it right there. So there, you get the little needle that pokes in there. Or you could just start your IV, draw out 15 or 20 milliliters, and go from there. So once you fill all those little tubes, red, blue, green, lavender, you don't want to shake them, especially the red tube, because they all have different chemicals in there. Remember that. You just want to turn them back and forth, just agitate them a little bit, and they have to be at least 3/4 full. I think they all have a little line on them. All the ones I've seen anyways, they have a little line on them telling them how much that they have to be filled. And they'll suck in the blood until they're pretty much full. Blood type is identified by obtaining a type and cross match. So that would be like your A positive, B positive, AB positive, all that stuff. They're going to run a bunch of tests on your blood before they give you a blood transfusion, ideally. Chapter 13, we covered that a little bit. But here we're talking about just a little bit more. Hospital has type O blood available for transfusion. Then, depending on the size of your hospital, they might have all the different types of blood. Some of your more outlying or smaller services might just have some O negative, 1 or 2 units of O negative available. For transport, of course, verify your type and the RH factor, so A negative, B negative, all that, before you leave, if possible. Check to see if they're having any reaction, how long that blood's been flowing, and be mindful of any reaction that could occur. You need that larger IV site, remember 18 gauge, really, or larger for blood, otherwise it's going to hemolyze or clot up. It's going to damage, if you're going through a real small vein or a real small catheter, it's just not going to flow well, plus it could damage those red blood cells. If you're trying to flow it through a 22 or 24 gauge, you're going to damage those red blood cells and they're not going to be able to carry oxygen once they get into the vasculature anyways. So we need that larger IV size. If a reaction occurs, discontinue the IV lines, of course. Checking that vital signs every 5 minutes, monitor for those hemolytic reactions, which is a whole nother chapter. But always, if there's any reaction, especially a fever is going to be a big one to watch for, or a rash or itchy throat, stop the blood immediately, consider Benadryl, treat those other symptoms, and reassess them frequently. All right, an IO. IO is just as effective as an IV. You can give any fluid or drug that you want to give via IV. You can also give IO. IO, you're just drilling a hole into the bone, putting a needle into the bone pretty much. Lots of different sites that you can give it. Legs, arms, chest. You are going to want to put the actual catheter, or you're going to drill them right into this area, the metaphysis, and right below the epiphysis. Epiphysis? Yeah. Into the spongy area right in here. There's lots of vasculature there that it can then join the rest of the veins. IO space comprises spongy cancellous bone of the epiphysis and medullary cavity of the diaphysis. Sounds like a good test question. So again, right up in here. If you get down in here, it's really thin, it can be hard to hit, and it's not as good of a spongy area. This is your best bet right in there, at each end of the bones. IO space remains patent even if IV access is difficult. Quickly absorbs IV fluids and medications. So you can give it, if you can't get an IV for whatever reason, you've tried and tried and tried, and you have to have an IV, or you have to have access, vascular access, go with an IO. It is expensive. They do cost a lot more per attempt, but it's a lot less risk for errors and works really well. Okay. 3 common sites: sternum, humerus, proximal tibia. Those are common sites, but there's lots more. You can do distal femur. You could do distal tibia or distal fibula if you had to. They say the actual insertion of that is just as painful as an IV. It, I guess, doesn't hurt to drill it into the bone. It's just, poking it through the skin where the pain is. But once you push fluids into that cavity of the bone, that's where the pain comes in. And you will see people come off the cot once you try to push fluids in, if they're alive, that is. You want to try to pre-treat that with some lidocaine or something. Humeral IO. Manipulate the arm and palpate the humeral head. There's some YouTube videos out there. It kind of shows you the proper technique for doing that and getting that good IV site for all of these. So proximal tibia, that was kind of I would say pretty much everybody's first line. Flat bone is medial to tibial tuberosity, the bony protuberance just below the knee. You're going just below the knee and just to the medial aspect there. Distal tibia is okay as well. Not as popular as that proximal tibia. Different types of IOs. Yeah. There's a bunch of different styles out there, so just whatever your service has, get familiar with it, practice with it, and be ready to use it. Essentially, it is a needle that you push through the bone, and then it's got a catheter on the inside, another needle that you withdraw out of it. You have to kind of twist it in there. This one here has a bunch of different needles on it. I think there's about 10 or so needles on this fast device that goes into the sternum. That just looks painful, but whenever you're using that fast device into the sternum, it's going to go above the site where you would do CPR, so you can still do CPR with it. Easy IO is probably the most popular nowadays. It has a little battery-operated gun drill, and then you put the needles on there, the red, the pink, the blue, or the yellow. The yellow is a long one. It's for those larger patients that you have to go through that adipose tissue. Blue is your standard adult, and then the pink is going to be your pediatric size. They're all 15 gauge needles in diameter. They're just different lengths. And it says there it inserts the IO into the proximal tibia. Just know you can use that easy IO in any of those sites. Any IO site. It doesn't have to be that proximal tibia. Again, just another brand. The big spring-loaded device inserts IO into the proximal tibia again. Just different brand. There's another one, the new intraosseous device. Spring-load device that contains neither drill nor battery. You just push it down and shoots it in there. Line the adhesive target. Prepare the insertion site on patient's manubrium. Line the stabilization needles. So it's just telling you how to do that there. Like I said, you're going to just want to practice with whatever your service has and get familiar with that one. Extravasation is a thing. If you go all the way through the bone, and you're going to just be mindful, watching for swelling or edema around that site once you initiate it. Osteomyelitis, inflammation there, can happen. Failure to identify the proper anatomic landmarks can damage the growth plate, so that's why we want to be careful and just go right there at the end of the bone so we don't hit that growth plate, especially with the kids, and damage that. Overall, relatively low complications with an IO. If there's same as with an IV, you don't ever want to start it through an active wound. If they've got a rash or something on that site, choose a different site. I think it talks about... Yeah, okay. Improper technique can cause a fracture of that bone, of course. Try to be careful. Through insertion occurs when the IO needle passes all the way through. That's where you're going to get that extravasation, where you've pushed it all the way through and then you push fluids in. A PE can occur if particles find their way into the systemic circulation. It's possible. Functional IV line is available. This is when you're not going to get an IO. Again, it's not our first line. IO isn't our first line. IV is always preferred. A lot less cost. Fracture of the bone intended for IO cannulation, osteoporosis, osteogenesis imperfecta, bilateral knee replacement, prosthetic limb. Prosthetic limb, I don't know why they have to put that on there. I think that's obvious. If you're missing your leg, you're not going to start an IO there. Bilateral knee replacement, you're going to have to choose a different site. Go someplace else. If there's, pieces of metal in that knee and there's screws and all that stuff, you're not going to be able to start an IO there. Go with humeral head, distal femur, something else. Follow your protocols. Okay. Medication administration. This gets into the math of it all. Good deal. Understand how medications affect the human body before administering them. Review Chapter 13. Review all your medications. Be familiar with them. You're going to have a lot of them memorized. Everything in EMS, in the healthcare system, when it comes to medications, is all going to be based on the metric system. You're going to have to learn the metric system, starting kilograms, milliliters, all that good stuff. We don't use the English system. We don't give tablespoons of medication or ounces of medication. It's all done in grams, kilograms, milliliters. So, if you're not familiar with the metric system, you're going to get familiar with it. It's all based on a set of tens. Grams, kilograms, all that is tens. Milligrams, micrograms. I like the metric system. Once you're familiar with it, it works out pretty well because it's simple. It's all about dividing or multiplying by 10. When dividing, you move the decimal place to the left. When multiplying, move the decimal place to the right. So dividing by 10 would move it 1 decimal place to the left, and then multiplying it by 10 would move it 1 decimal place to the right. Percentages are part of 100 and use the percent symbol. The metric system, based on multiples of 10, measures length, volume, and weight. There's a nice little figure there that shows you all that. Tenths, hundredths, thousandths, all that. For everything length-based is going to be in meters, kilometer, meter. Volume and weight, which is what we do most in EMS, volume will be liters, milliliters, deciliters, any of that. And then weight is grams, micrograms, milligrams, kilograms for weight. Grams, weight. Liters are volume. Meters are length. Metric system. Prefixes demonstrate the fraction of the base being used. So standard unit of measure for volume is the liter, and then that prefix changes things. So the kiloliter would be 1,000 liters. Milliliter would be 1/1000th of a liter, and microliter would be 1/1,000,000th of a liter. Grams, same thing there on the right of table 14-5. And then 14-6 there. We use a lot of micrograms. Milligrams kind of gives you the symbol that you're going to use for whenever you abbreviate those. Drugs are supplied and packaged in a variety of weights and volumes. You will be required to convert weights to volumes and volumes to weights. Just get used to it. One thing to keep in mind, a milliliter and a cc or a cubic centimeter are the same thing. So some syringes might say 1 cc or 1 milliliter. Just know that those are the same thing. 100 milliliters would equal 1 deciliter, and 1,000 milliliters would be equal to 1 liter. When it comes to the weight base there, 1 microgram it would be 1/1000th of a gram, 1 of a milligram. 1 milligram would be 1,000 micrograms. 1 gram is 1,000 milligrams. And 1 kilogram is 1,000 grams. Just look all this over. Study it. Use some other resources to kind of get familiar with the metric system if you're not. We're going to be practicing it a lot. You're going to be converting all this stuff. Volume conversion. Pre-hospital setting uses two measurements of volume, milliliters and liters. Remember, 1,000 milliliters equals a liter, right? Yes. 1,000 milliliters equals a liter. So if you're converting from a milliliter to a liter, divide the smaller volume by 1,000. If you're converting a liter to a milliliter, multiply the liter by 1,000. So if you got that big old bag of normal saline, the big bag, it's 1,000 milliliters. It's also equal to 1 liter. 33.8 ounces, I think. Yeah, 33.8 ounces. But in EMS, all the medicals, we use milliliters and liters. Weight conversion. Larger unit to small, multiply the large by 1,000, or vice versa. We use kilograms for all of our weights. Converting pounds to kilograms. There's two different ways to do it. If we want to divide the patient's weight in pounds by 2.2, or we can divide the patient's weight in pounds by 2 and subtract 10%. So if you're using a calculator and you've got someone who is 220 pounds, 220 pounds, divide that by 2.2, gives you 100 kilograms. I don't have my calculator pulled up here. Another way we can do that is divide the patient's weight in pounds by 2 and subtract 10%. So we got 220 pounds, divide it in half, get 110, and subtract 10%, which would be 10. 110, or it'd be 11. 10% of that, divide it off. There we go, 100 kilograms. The way I do it personally is I divide the patient's weight in half and then subtract 10%. Whatever that last digit is, subtract that off, pretty much. So here's another example. I've got someone who's 280 pounds. Divide it in half, that gives me 140, and then subtract 10%, 14. So that takes me from 140 down to 126. So I got 126 kilograms. Again, I know this is visual. It's hard to just listen to this and have a good concept of it. So practice converting pounds into kilograms. We don't really ever need to convert kilograms into pounds. We're just always going to be converting pounds into kilograms, because most people don't know their weight in kilograms. Temperature conversion. Typical normal body temperature is 98.6 Fahrenheit or 37 degrees Celsius. So to convert Fahrenheit to Celsius, subtract 32, then multiply by 0.555 or 5/9. To convert Celsius to Fahrenheit, multiply by 1.8, then add 32. That's not a conversion that I have memorized. I'll take someone's temperature and document it in Fahrenheit. If I want to convert it to Celsius, then there's a little button I can push on my thermometer to convert that. But generally, we can get by with just using Fahrenheit on our temperatures for EMS. All right, desired dose. It's the amount of drug ordered by the physician. Given fentanyl, someone's broken their leg, 50 micrograms. That's our desired dose. Okay, that's what our protocol says that we need to give. That's our desired dose. It's always going to be a number and then a unit of measure. So micrograms, milligrams, grams. That weight. The drug concentration. Total weight of the drug contained in a specific amount of volume. So this will be on our little vials that we'll see. It says 5 milligrams and 2 milliliters, or whatever it might be. That's going to be the drug concentration. How much of that drug, the weight of it, the milligrams, are in that volume of fluid. The volume on hand is the volume of solution that the drug is contained in. So like I said, 5 milligrams and 2 milliliters. That 2 milliliters would be the volume on hand. Weight of drug present in milliliters equals, in 1 milliliter, equals our concentration. So if we have 5 milligrams and 2 milliliters, we would have to divide that down to get our actual concentration. So if we have 5 milligrams and 2, that would give us 2.5 milligrams in 1 milliliter. Our concentration would be 2.5 milligrams in 1 milliliter. Hopefully you're able to follow that. The volume to be administered. We take our desired dose, whatever the physician tells us, whatever our protocol says. Desired dose divided by the concentration of drug on hand equals volume to be administered. Okay? For example, let's say fentanyl. Desired dose is 50 micrograms. Our concentration of drug on hand, say we have 100 micrograms per milliliter. Okay? So we have to take our 50 micrograms divided by 100 micrograms and 2 milliliters. I don't have any way to show you on the screen here, but that would be half of a milliliter. We'll cover all this more. I promise there's other handouts that show it. We're going to be practicing this a lot to get a good base for you guys of how to do all these dosages. Look at your books. There's some examples in your books too. The one we'll use quite a bit it's called DD times V over DH. So our desired dose times volume divided by dose on hand. All right. Whenever you're, we'll just go on. Okay, weight-based drugs. Medication doses are based on patient's weight in kilograms. This is especially true for the kiddos. Everything we give to the kids is weight-based. Epinephrine, atropine, everything. Solumedrol. It's all weight-based. So that adds in another factor that we have to get. We don't know our desired dose of the medication until we figure out the patient's weight and then multiply that times what our physician has ordered. So if they've ordered 1 milligram per kilogram and the patient weighs 10 kilograms, then our desired dose would be 10 milligrams. Okay? We have to do it in kilograms also. Always in kilograms, never in pounds. Calculating fluid infusion rates. Adjust the flow rate based on patient's condition. To calculate the flow rate, volume to be infused times our drop set. Remember we talked about macro or micro, 10 all the way up to 60 drops per milliliter, divided by the total time of infusion in minutes. Okay? That gives us our drops per minute. For an example on this one, this is going to be, calculating or giving fluid boluses. So volume to be infused, say we start with a 1 liter bag or 1,000 milliliters. Our drop set is a 10 drop set, so we get 10 drops per milliliter. That would be our number that we're going to plug in right here. We've got 1,000 milliliters times 10 GTT/ml. Total time over infusion, let's say 4 hours. So that has to be converted down to minutes. So 60 times 4 would be 240 minutes. And then we just simply plug that into our calculator. So 1,000 times 10 divided by 240. 1,000 times 10 would be 10,000 divided by 240 gives us 42. 42 drops per minute. Non-weight based. If it's non-weight based and we're giving a drug infusion over time, it's going to be the same thing. Remember, if we want to make it weight based, it gets a little bit more complicated there. Same idea. We're going to be, like I said, other resources there, and we're going to be practicing this a lot. Weight based, you use the same formula. You can use the same formula, but it also is going to factor in the patient's weight in kilograms, and then also that desired dose will be added to it. Like I said, look it over in the book, get familiar with this, read this style. There's lots of YouTube videos. There's tons of different ways of doing drug calculations. You don't need to go out and buy a special book for drug calculations. We have other resources that we'll be using here. Curtis and Lacey will let you know exactly what formulas that they want you using we'll get all this figured out, all right? We'll practice, practice, practice. For the kiddos, there's lots of different resources we can use. Pediatric length-based tape, Broslo tape, maybe the Hand-Tevi app, different things we can use to get our dosage there. The nice thing about a lot of those is they will not only just tell you your desired dose, but they will also tell you your volume to be infused. And that way you don't have to do the math on it. Makes it really simple, really good. Now, kids are going to be very stressful situations, so you want to reduce that, having to do those calculations in your head. Again, it's all going to be based on kilograms for that. Enteral medications, anything you're giving enterally is something that goes through the digestive tract, whether it's a rectal suppository or down through the mouth, something they swallow down. Lots of different forms of it there. It's a relatively slow absorption rate for that. It depends a lot on GI motility, and gastric contents can affect how well that stuff is absorbed into the body. We don't give a whole lot of medications enterally. Most of the stuff we do in EMS is parenteral, where we avoid that GI tract. Always check your 10 rights prior to administration, of course. Determine the need for the medication, get the history, follow your protocols, and check the medication and determine the dose. Those are part of it. Instruct the patient to swallow with water, possible. Monitor the patient and document findings. So it looks like he's going to have him chew up some aspirin here. We're going to give that enterally. That and oral glucose, activated charcoal. I'm trying to think of any other enteral medications. Those are kind of a big three that we might give. You can start an OG tube or an NG tube, where it is just a tube that goes down the esophagus and into the stomach. And OG versus NG, if it's orally through the mouth, it's OG. If it's a nasogastric, that means it's just going through the nasal passage and then down the esophagus. You can use that to decompress the stomach and actually hook it up to suction. Perform a gastric lavage. You're going to pump a bunch of fluids down in there and then suck it all out. And you can also push medication down that, or nutrition if you needed to. Rectal administration. Medication absorption is rapid and predictable. Some medications are available in the suppository form. Not so much in EMS, but what we might see it for is rectal Valium or Versed for a lot of times the kids, pediatric patients with seizures. They do it as emergency medication. If the kid is seizing real bad, then we can give them rectal Valium. The mom or dad or guardian or whoever is prescribed that and has that, and you can give that to them rectally. Help with that seizure control. Determine the need, obtain the history, follow the orders, of course, determine the dose and ensure it's correct. Lubricate and insert into the rectum 1 to 1.5 inches. Make sure you get it all the way in there. No needles on that. Don't try to put any needles up in there. It's kind of a blunt thing. Modifications may be needed for liquid form. Lubricate it. Tell the patient not to bear down, not to push it out. And then dispose of it after it's done. Parenteral. Any route other than the GI tract. So this could be intradermal or transdermal, where they have a patch on that they're absorbing in. Could be buccal or sublingual, whenever we're spraying nitro in there and it's absorbed in the mouth. That's going to be technically, I believe, a parenteral route, because it's not going in all the way down the gut and stuff. Syringes and needles are necessary for that. Syringes consist of a plunger, the body or barrel, the flange, and the tip. Well, there you go. Most syringes are marked with 10 calibrations per milliliter on one side. We always want to try to use the smallest needle or smallest syringe possible to get our volume. So if I need to give the volume of 1 milliliter, I'm going to use a 1 milliliter syringe. Most common syringe sizes are going to be like 1, 3, 5, 10, 30 milliliters. I'm going to use the one smallest that I can. That way I can be the most accurate as possible. It's hard to accurately draw up 1 milliliter of fluid into a 20 or 30 milliliter syringe. It's easy to accurately draw it up into a 1 milliliter syringe. We want to be as accurate as possible so that way we don't risk over medicating the patient. So, hypodermic needles, of course, vary in length, vary in gauge. Larger needles are going to be used for that intramuscular, and smaller needles, shorter needles, will be used for like sub-Q administrations. Proximal end of needle attaches to the standard fitting on the syringe. It's like a lure lock. The distal end is beveled. It's not just a blunt tip, it's beveled. Ampules, I don't know. I don't know why these were invented. I don't know why they're still in existence. It is a terrible way to get drugs, but it is a thing. You have to break the glass container to get the drug out of it. I don't understand why they're there. So once you break that glass, then you have to use a special needle because you have contaminants in your medication. You have to use a filter needle that'll filter the glass out of your medication. Then you got to throw that filter needle away, put another needle on, or then attach it to your lure lock and give the medication. I don't know why they're still in existence. A vial makes sense. It's a glass container or a plastic container with a rubber stopper on the top. Seems very simple. Can have single dose or multiple doses. Once you pop that little cover off the top, it's no longer sterile, but it can still be a multi-dose vial. So you want to cover that back up, and then you're also going to clean the top of that. If it was ever needed for multi-doses, you're just going to clean that top with alcohol, some sort of aseptic technique to make sure you don't have any germs on top of that before you poke through it with the needle. Another kind, you'll see that with Solumedrol, is a mixo vial where you got two compartments. You push down on that little orange stopper on the top, and it actually pushes the little rubber stopper in the middle, pushes it down in there, and that way the fluid at the top and the powder in the bottom mix together. Pretty cool little idea. And then the very top has a little rubber stopper that you can draw the medication out of after you've mixed it up. Pre-filled syringes, self-explanatory. If you're using one here on the left, you pop that little yellow cover off, and screw those together. Then you have to make sure you get your air out of that and get this little rubber plunger stopper down to whatever line of medication your starting point is. That's how you're measuring it. This one on the right seems pretty simple. You take the lid off of that, and then you just push in the medication. Pre-filled syringes there. Single-dose medication cartridges are also a thing. That Carpuject there. The problem with Carpuject is you have to have one of those special tools there you see on the left to push that medication in there. That's the most efficient way to do it anyways. I'm sure somebody was making money on it, so they developed that. Don't see them near as often as you used to. Push-dose pressors here. Some are available pre-made, and sometimes you have to mix those up on your own if you need that. Most common if you want to do a epi drip, or a push-dose epi. It's on page 736 here in your book. But you'll take a cardiac epi, that 1 to 10,000 concentration, and then a saline flush. You're going to waste 1 milliliter out of a 10 mil saline flush. So you got 9 milliliters left. You're going to take a blunt tip needle, or there's a little lure lock conversion adapter. You're going to draw 1 milliliter out of that epi, 1 to 10,000, and draw it into that saline flush. That's going to give you a concentration of 100 micrograms in 10 milliliters. And when we're doing push dose epi, standard dosing is like 10 micrograms, 10 to 20 micrograms. So that'd be like 1 to 2 milliliters. So look at that in your book, and of course you're going to follow your protocols, but it does mention that. Intradermal involves administering a small amount of medication into the dermal layer, so just below the skin, just below it. If you're getting the TB test, it's going to be intradermal, okay? Have a slow absorption rate. Of course, check your 10 rights. Cleanse the area, pull the skin tight, insert the needle at a relatively low angle, 10 to 15 degree angle, just underneath the skin. Slowly inject the medication. You can only give just a little bit of medication underneath the skin, though, otherwise it's going to all come out whenever you pull your syringe out. So, TB test, not much else we're going to use that for. Subcutaneous is going to be a little bit deeper, given into the connective tissue between the dermis and the muscle. Give that in the upper arms, anterior thighs, or the abdomen. A lot of people are getting insulin injections, are doing it sub-Q into the abdomen. There you go. Goes into that subcutaneous tissue there. If you're doing the transdermal, it's going only into that dermis right there. So it's a little bit shallower area. Anterior thigh, abdomen, upper. Intramuscular, that's where we change our angle. We're going to come in at a 90-degree angle, just like when they're giving it IO. And you're going to go all the way into the muscle. You want to choose an area with a large amount of muscle, and it will help it absorb better. So you go in about an inch, inch and a half into until you hit that muscle, and then give your medication. You can give more volume of medication in those areas too. In the upper arms, 1 milliliter, maybe 2 milliliters, and then if you give it in a large muscle like the gluteus maximus or something like that, you can give maybe up to 5 milliliters in that muscle tissue. And then you kind of want to massage it in after you give it. Deltoid there is my favorite go-to for ketamine. Hit them with 50 milligrams of ketamine IM based on my protocols. And then massage it in. And it starts working within just 3 or 4 minutes. Gluteus maximus is another good site there. Look at your skill drills on page 741 for kind of some more information on that. IV bolus. So we start that IV, we give a medication through that IV. It goes directly into the circulatory system. Remember, 100% bioavailability. It skips out on first pass filtration through the liver. So we're getting it all into the system. Ideally, you're going to use a needleless system. So once you start your IV, you don't have to use any more needles in the patient or around the patient, reducing that risk for stick. A bolus is a single dose given by the IV route. That can be a fast push bolus or a slow push bolus. Virtually all of our medications that we're going to give are a slow push bolus over a minute or two. Only time we give a fast push bolus would be adenosine, because the half-life of adenosine is like 10 to 12 seconds. So we need a fast push bolus into the IV, and that way it can get to work before it's eliminated by the body. All of our other medications we're going to give as a slow push bolus over a couple minutes. It could be, a milliliter or two, or it could be 100 milliliters. Depends on what the medication is, but it's going to be that IV bolus. We're just pushing it all at once. We're not hanging an infusion of it. That's the differentiation there. Determine the need for the medication. Again, it goes back to checking our 10 rights. Make sure the patient needs it. Assemble the equipment, drop the medication. Cleanse the injection port or remove the cap. Try to not really sterile at that point, but try to reduce any contaminants, cleaning your IV site there with alcohol, all that. Give them the medication. It says pull back on the plunger and observe for blood. So that's just you're pulling back on that IV to make sure that you're not clotted off there. That vessel hasn't become occluded. If it had, you'd hit it with a 10 mil flush first, try to get rid of that occlusion. And then you dispose of your medication after you're done with it and flush your line. You can also add medication to a bag. Like we mentioned, D5W, we're going to mix medications into that bag. They have a separate little port on there. You can use a little needle and push in the medications. And then agitate the bag, mix it back and forth to make sure it's all mixed up. Make sure you label that bag of what medication it is, how much you put in there, date, time, all that stuff. They'll probably just throw it away once you get to the hospital anyways, but that way you can keep it straight in case they need it.